Okay, I'm going to do this quick thing. Let's just do this fast with the math. It'll make more sense. So we have the arterial end of the capillary. The hydrostatic pressure of the capillary, 35 millimeters of mercury. We know the oncotic pressure is about 25 of the capillary. On the venous end, we know that hydrostatic pressure is 15. Where did that 20 units go? In the interstitial space. We're favoring filtration. We're losing blood volume a little bit because it's being pushed into the interstitium. So, on the arteriolar end, if we set up the equation, PC minus PI minus oncotic pressure of the capillary minus oncotic pressure of the interstitial space. So on this end, we get 35 minus 0 minus 25 minus 0. 35 minus 25 equals plus 10. Therefore, on that end, it's going to what? Favor filtration or oppose filtration? Favor filtration. We're a plus 10 on the arteriolar side. So we're favoring filtration. Now we're going to go on the venous end of the capillary. Now we're trying to collect all the waste product and go to the venules and the veins. Set up the same exact equation. But now it's 15, it's not 35 anymore. Minus the oncotic pressure is still 25 in the capillary, and it's still going to be 0 in the interstitial space. So now we get 15 minus 25 equals negative 10. On the venule end, what force wins? The suck. The forces that oppose filtration, the oncotic pressure, is greater than the force that favors filtration. The suck wins. So now you see on the arteriolar end, it's all hydrostatic pressure. On the venous end, it's all oncotic pressure. Okay? Makes sense better with that one? Okay. Okay. Moving on to the lungs. Yes?
Quick question.
Yeah.
So what is the 10 referring to?
The 10 is just the difference between oncotic. Yep, the pressure difference. If it's positive, that means we favor filtration. If it's negative, we oppose filtration. That's all. Okay, lungs. Follows a lot of the same principles as the heart, so it kind of goes along, not so bad. The primary homeostatic variable is the partial pressure of oxygen in the blood. So in the cardiovascular system, it's cardiac output. Pulmonary system is just what's the concentration of oxygen in the blood, in the arterial blood. The rate of O2 uptake and CO2 excretion at the lungs must match the rate of O2 use and CO2 production. If they don't, will you be able to get enough oxygen in? Nope. Will you be able to exhale the CO2 enough? Nope. And that's where we start thinking about those things. Main components are the lungs, the chest wall. We bring in that now. We're going to talk about the chest wall. And our pulmonary blood vessels. Our levels of O2 and CO2 are monitored by chemoreceptors. What did we have in the cardiovascular system to check things? We had baroreceptors to check the pressure. Now we have to know what's going on with our arterial O2 and CO2. So chemoreceptors monitor that change and they tell the brain what's going on. So we have to talk about things that govern ventilation. So ventilation is just flow of air. Nothing to do with oxygen or CO2. Ventilation is just air movement. Diffusion of gases and perfusion. What's the blood flow in the lungs? So ventilation and perfusion. Ventilation just means air is moving. Perfusion means blood is getting to the lungs, because if there's no blood in the lungs, will gas exchange ever happen? No. So you have to have both. Ventilation and you need perfusion. If you have perfusion but no ventilation, will anything happen? Nope. So parts of your lungs right now aren't being perfused because you don't need it. Why waste the blood if there's no oxygen in that area? Likewise, you could have ventilation but no perfusion. Will any gas exchange happen there? No, there's no blood in the area. You just have ventilation. No blood to get that oxygen. We call that dead space. Nothing's happening, but there's air there, but nothing's going to happen to it. Blood-gas interface. We talked about those capillaries. Has about 300 million air sacs. Okay? Each of those air sacs, the alveolus, has a good supply of capillaries surrounding each alveolar bud, or whatever. They look like a bunch of grapes. Okay, so we have great diffusion. We have plenty of capillaries, blood surrounding all the alveoli. Plenty of places for gas exchange to occur. So again, ventilation is just the air entering the lungs and going into the alveoli. All alveoli have a lot of pulmonary capillaries around it. Blood-gas interface is less than 1 micron thick, has 4 elements in series. So we talked about diffusion distance, right? The greater the distance, the weaker the diffusion. These are the 4 layers that oxygen and carbon dioxide must go through for diffusion to occur. We have a thin layer of surface liquid in the alveolus. That's our surfactant. We have our alveolar lining. Then we have a thin layer of interstitial fluid. And then finally, we get to our pulmonary capillary endothelial. You have to go through 4 layers. So that thin layer of surface liquid, that surfactant that's in the alveoli. Let's say you got like bronchitis. Okay? What do bronchitis patients have a lot of? What do they produce a lot of? Mucus. Okay? They cough a lot. All that mucus that's there. Well, that mucus, if that gets into the alveolar sac, don't you have another layer to get through now? You're increasing the diffusion distance by all that mucus layer that's there. Therefore, you have weaker gas exchange, and their O2 sats drop. They're not going to be like 80, they'll be like 90s, but it'll be lower than normal because diffusion distance has gotten greater because of the mucus that's there. Or any of these layers increase in thickness, you're going to increase the diffusion distance, you're going to slow down gas exchange. Gas exchange is all done via diffusion. We have inflow of oxygen-depleted blood. And as you come into the alveoli, you can see we start dumping on absorbing O2, and we diffuse out CO2 so we can exhale the CO2. And this goes on throughout the capillary. So the O2 concentration is going to be higher in the lungs than it is in the blood. So O2 will diffuse from the air into your blood. CO2 concentration is higher in the blood than it is in the air. Why is it higher in our blood than it is in the air? We produce CO2 as a byproduct for all of our energy metabolisms. We produce CO2. So we're going to have more in our blood than the air, so that diffusion goes from the alveoli to the air so you can breathe it out. If that wasn't there, you wouldn't be able to breathe out the CO2, and you get a lot of problems with that. Gas laws, just like in the cardiac section, you don't need to know what the law is, but understand that the law is there, and that's how we can get our certain pressures in our in the blood. So Boyle's law is airflow into lungs on inspiration, the pressure of a gas is inversely proportional to its volume. So we talked about blood. Blood is not compressible. So when you squeeze like a water balloon, you're generating pressure inside that water balloon, and the weakest part will bubble out and give you a big bubble where the water is going to go. So you can compress blood, but it starts generating a lot of pressure. Air is the opposite. The more air that you have, the less pressure is in the lungs. So lung volume is first increased when your inspiratory muscles expand the chest, but as you start to breathe in, the pressure in the lungs, because you're adding more volume, drops inside the lungs. If it didn't do that, you could never breathe. And you have to think about breathing. Breathing is passive because the minute you breathe in, pressure drops in the lung and air just gets sucked into your lungs and you can breathe. And then you breathe out. We'll talk about the muscles that help with expiration later on. So Boyle's law. If you try and compress the more volume of air, the lower the pressure. So it draws air into the lungs. Next, Dalton's law. Each gas has a partial pressure that's proportional to its concentration. In the air right now, out of 100% of the air that we breathe in, what percent is O2? What? About 21%. 21% of the air you're breathing in right now is oxygen. What percent of the air in the atmosphere is CO2? 0.03% of the air is CO2. The rest of it is either nitrogen or water vapor, and other things in there too. But those are the key numbers. So if we know that 21% of the air you breathe in is oxygen, then you can figure out that of the air, 21% of it is oxygen. You can figure out the math from there. So all adds up to gases in the air. So therefore, estimates that alveolar O2 partial pressure is similar to what it is in the air. Anyone know what's the total number for partial pressure in the air? How many bars or barometric pressure and all that fun stuff? I think it's like 760 is like the total number in the air. So of 760, 20% tells you like there's 100 and something units of oxygen in the air. And you'll see where that translates into your breathing later on. The last thing is talking about Henry's law, and that states that the volume of gas that's dissolved in a liquid is directly proportional to its partial pressure. And that's just how do we get these partial pressures of O2 and CO2 has to do with the air that we're breathing in. Water vapor. We have to humidify the air. No matter how cold it is outside, when you breathe in, you may feel the cold hit the back of your throat, but by the time that air hits the alveoli, it's already been warmed up and moisturized to your body temperature. Okay, we have to add humidity to it. That's why if you breathe, you get all that moisture out of it, but if you breathe faster, you don't get it. But there's moisture and there's water vapor in the lungs that we add to that water vapor. Because we add in water vapor, it displaces some of the oxygen, which is why the oxygen is not near perfect the way it is in the air. In the blood, it's a little bit lower because we had to add in water vapor. And it occupies that 100%, it kicks out some of the oxygen. So the inspired PO2 is reduced because you're adding in water vapor to humidify the air. Let's talk about how we actually breathe. Airflow into and out of the lungs relies on the pressure gradient from one point to another. The steeper that gradient, the better flow is. Same principles in cardiac, okay? All goes together. The greater the gradient, the better the flow is. We talk about the gradient from the left ventricle to the right atrium. Here we're talking about from the mouth to the alveoli. And as we breathe in, pressure drops, allowing air to go from a high pressure out in the atmosphere to a lower pressure in the alveoli, and air comes in. You don't got to think about it. Breathing becomes more difficult if the chest wall is stiff. Low compliance. Here's that compliance again. Okay, think about if you had a straitjacket. Okay, you're trying to expand your lungs, you can't do it. Our compliance has reduced. Okay, so it makes it harder to breathe. Or if the resistance to gas flow is high. So you have restrictive lung diseases and you have obstructive lung diseases. All depends on where the problem is. So resistance to flow is a dynamic property determined during the gas flow. Compliance is an elastic property and is measured without gas flow. So we look at elasticity, the compliance, you can just be breathing normal, but resistance has to deal with flow of air. Compliance is more dealing with tissue. The lung parenchyma, the actual lung tissue. If that lung tissue gets stiff, your compliance is going to get worse. Resistance is a flow property. Is there anything in the way that's causing flow to be resisted? So we are going to be dealing with lung volumes. We're going to draw this out, but there are 4 lung volumes, and then we have lung capacities. Capacities are volumes added together. Okay, so a capacity is 2 different lung volumes added up, or you can have individual volumes, and we'll draw this out in a second here. But these are the terms that we're going to be talking about when we draw it out. So these are called lung spirometry. We have spirometry units here in the building. You guys will be doing those breathing things during labs. You can actually test your own, see your age of your lungs. But we want to figure out what's going on with your lungs when you're breathing normally. So we're going to label it all out. There's a couple of things that are very similar to the way it is in the heart. So in the heart, we have cardiac output equals what? Okay. In the respiratory system, we have something very, very similar to that. We want to know cardiac output is just the total amount of blood in and out of the heart. What is the thing that we measure when we want to talk about air moving in and out of the lungs? What do we call that? Ventilation, right? Air moving in and out of the lungs. So in the lungs, we have ventilation equals, instead of stroke volume, we have what's called tidal volume. How much air you're moving with each breath. So right now, you are all breathing tidally, like with the tides, in and out. You breathe in, you breathe out. You breathe in, you breathe out. Okay? As you PAs will know, the minute you tell someone to breathe, then you can't breathe anymore. I don't know why that happens. They say breathe or swallow for the thyroid, swallow, and you can't do it. But you can do it normally, but they tell you to do it, then you forget. So we have tidal volume. What's the air moving with each breath? That's like stroke volume, right? The amount of blood leaving the heart with every beat. Now we're looking at how much air you're moving with every breath. Instead of heart rate, what do we measure for respiratory? Respiratory rate. How many times do you breathe a minute? So if you take your tidal volume, how much air you breathe with each breath, multiply it by how many times you breathe in a minute, that's going to tell you your ventilation. Very, very similar to the cardiac output. How much do you put out with every beat? How many times do you beat a minute? How much do you breathe with every breath? How many times do you breathe a minute? So our tidal volume looks just like this. You breathe in, you breathe out. You breathe in, you breathe out. That's tidal volume. I'm going to put it over here, and I'll put it in the line here. So this area is our tidal volume. Now, if you took, I'll draw it in a different color, I'll put it in blue. If you said, okay, breathe out, now breathe in all the way in so you can't breathe in anymore. Okay, that's what we're doing now. We're bringing this all the way up, okay? And we'll bring it all the way up. So we're breathing in. Okay, you all have this reserve volume for inspiration. Even though you're breathing normal, you can still bring in a whole heck of a lot more air when you do a deep inspiration. So this is a deep inspiration, and you breathe it out. Then we're going to say breathe all the air out. Breathe it all out. Keep going, keep going, keep going. I'll put it in purple. Okay, and then we go back to tidal volume. Now, everything above the tidal volume up to the max is called your inspiratory reserve volume. It's the reserve air that you can breathe in above a normal tidal volume. AAs, one of the big parameters you guys got to know is what's called end tidal CO2. End tidal, as you breathe out, by that point, you should have breathed out a lot of that CO2 that you were generating through that one exhalation. We want to know what that end tidal CO2 is, because depending on where that is, you're going to have to alter some things in your taking care of the patient. So that's our inspiratory reserve volume. We also have, if you look at from the bottom part of the tidal volume to the bottom part is our expiratory reserve volume. Everything you can exhale out beyond that. We have one more volume that we don't draw on here, but we know that it's there. It's called residual volume. And, oops. Residual volume. We talked about the heart. The heart has to have some volume of blood in it after every beat, right? What do we call that? The amount of blood that leaves the heart with every beat. Stroke volume. If we gave it a percentage, what do we call it? Ejection fraction. Remember, the heart can't eject all 100% of the blood because it needs blood volume in there to keep the heart popped out so it can maintain its shape. Your lungs are the same way. You cannot exhale all the air out of your lungs. There needs to be some remaining residual volume to keep your alveoli popped open. If you got rid of all the air in your lungs, all the alveoli would collapse and you'd have a very hard time breathing. So we always have a little bit of volume in the lungs. It's called residual volume. So these are the volumes. Now, if you take these volumes and add them together, you get what are called capacities. Okay? So we have the first one is inspiratory capacity, which equals how much can we inspire? That is inspiratory reserve volume plus your tidal volume is all the air, the amount of air that you can breathe in. So you breathe out, now breathe all the way in. All that air you breathe in, that is your inspiratory capacity. What volume of air can you breathe into your lungs? We also have expiratory capacity, expiratory reserve volume, plus your tidal volume. So how much can we inspire capacity? What's our capacity to expire? How much air can we get out? Okay, we have two more. Okay, we have vital capacity. What does vital mean? Life. Okay? All the air that we can bring in and out of our lungs for life, for diffusion and all that stuff to happen. So our vital capacity is inspiratory reserve volume plus tidal volume plus expiratory reserve volume. So the very top to the very bottom of this big graph, not including residual volume. We haven't gotten there yet. The last one is TLC, total lung capacity. What is the total amount of air we can get into and out of our lungs? This time we do include residual volume because it's the total lung capacity. So TLC equals vital capacity plus residual volume. It's the whole thing from top to bottom, including the residual stuff. That's your total lung capacity. So these are the only things you got to know about breathing. Well, there's more to it, we'll get to it, but as far as the spirometry work and the different volumes. So understand the volumes, and the volumes add together to make your capacities. Okay? Any questions about the spirometry? Okay. There's another test we do. Anyone here have asthma? They go for spirometries? What kind of stuff do you have to do?
I just go in and they don't do like analysis, but I get like albuterol sulfate.
But do you do breathing tests before and after the albuterol?
When I was young, I don't know.
Okay. So when you do those tests, we don't just have you breathe normal. We have you do all that to get your normal volumes. But we want to know how fast can you get this air out of your lungs. So we do this thing called a forced expiratory volume test. The one just means how much air can you get out of your lungs in 1 second. That's all we're doing with this test. So we get these graphs here. The bottom part of the graph, you breathe in. Now we're at this point, we breathe in. Now, breathe out fast, as hard as you can, all that air out. And it'll make this type of graph. And what we want to know is how much air you are able to get out in 1 second. If this number goes down, what are some reasons why you can't get as much volume out? These are your obstructive disorders. There's something in the way that's obstructing the flow leaving the lungs. This is why you do this FEV1 test. Now, I asked her because she gets albuterol. Albuterol is going to help make your lungs dilate so you get more air in. What they normally do is they make you do this test first, and they see how your circle is. Then they give you the albuterol, wait 10 minutes for the albuterol to have an effect, and they do this test again. If the test improves by like more than 10%, that's diagnostic for asthma, because we gave you a bronchodilator, reduce the obstruction, and air can move easier. So that's what this FEV1 is. How much air can you get out in 1 second? Yes?
So with someone with asthma, it would be smaller?
Yep. And so we can look at restrictive or obstructive lung diseases. If it's a restrictive disease, it's a filling problem. There's no obstruction to them breathing. They just can't expand their lungs to fill appropriately. Something is restricting the lungs from expanding. Okay? The other type are the obstructive diseases, asthma, emphysema, chronic bronchitis. Those are all chronic obstructive pulmonary disorders, COPD. They're obstructing flow. Bronchitis, a lot of mucus plugs in the area. Emphysema has a problem with the recoil of the alveoli. Asthma, smooth muscle swelling in the bronchus, mucus as well. Those are all obstructing the flow of air. So when you look at lungs, it's either a restrictive disease, they can't get the volume of air in, or it's an obstructive disease, flow is a problem. So on an obstructive disease, this is going to be affected. It may go like this. Flow is a problem. A restrictive disease is a volume problem. So if you look at the x-axis, this is volume. This is flow. In a restrictive disease, they're not going to have any problems with obstruction. The flow is going to be fine, but their graph is going to be smaller. This is restrictive. That's obstructive. This will not be on your test. This is just reinforcing what we're talking about with flow. So think about restrictive or obstructive. Is this restricting the filling or is it obstructing the flow of air? Muscles of ventilation. Diaphragm is the most important muscle of inspiration. Okay, PAs, you guys did your diaphragmatic excursion, so you saw where that diaphragm goes up and down. Here's our spine, the ribs are like a handle, they just go out. Okay, that's like a pail handle. And your external intercostal muscles help as like a faucet turning on and off, so out and in, out and in. But again, everything is to improve the flexibility of the rib cage to allow the lungs to expand. This is very important. Expiration is passive at rest. Right now, because of your recoil of your chest wall, as you're breathing out, the ribs want to collapse back in. They want to go back to their normal shape. So when you breathe when you breathe in at rest, you're all doing it right now, it's just your natural response of your chest wall, the ribs, to go back to its normal shape. That's why expiration is passive at rest. You don't got to think about it. With exercise, now you have to use muscles to expire. The abdominal wall is the most important muscle of expiration. Your internal intercostal muscles are at right angles to the external obliques, and they help. So the internal intercostal muscles aid in expiration with exercise. So if you're out of shape and you go running, where do you get those little pains? Side splints. Why? Because these muscles don't get used very often, only when you exercise, and you're out of shape. So now you're having to use these muscles to expire when you're running. They tire out real fast, and they give you side splints. That's why you're getting that. It's just a muscle cramp because you don't use your muscles. So if you ever have baby back ribs, it's all the little things in between. Those are the muscles you're talking about. When I taught high school, we did all the muscles, and we brought in chicken wings. And so I ruined chicken wings for them, too. I made them figure out the muscles in the different parts. So that's why you get side splints when you exercise, because those muscles aren't strong. You're not used to running. Now exercise causes expiration to be active. You have to use muscles. They don't work very well. You haven't used them. So they tire out. You get side splints. Airway anatomy. There's two different parts of the airway. There's the conducting zone. No diffusion happens here. These are just tunnels for air to travel. They're conducting zones. They just move air from one zone to the other. That's all these do. Then as you start getting into the bronchioles, and then finally into the alveolar ducts and the sacs, these are called transitional and respiratory zones, because this is where respiration occurs. Gas exchange, O2 and CO2 occurs in these zones all the way down in the alveolus. Okay, all these terminal bronchioles, the bronchus, there's no diffusion happening here. They're just moving air. That's all they do. Elasticity. We have elasticity in our lungs. It's generated from our rib cage. The pleural on the lungs is attached to the inside of the chest wall. They're just there by like suction, nothing else there. But if they come apart, what do you get? You get a pneumothorax, because the lung can't be kept open by attached to the chest wall. They came apart, the lung just going to shrivel up. So what you do is you have to reinflate the lung enough to attach it back to the wall. Sometimes they actually use like talcum powder. They put it in there and it makes it attach. So that's what we're looking at here. So the chest wall has some elastic properties. Always under elastic tension. The tension increases during inspiration. So if you all breathe in, you can feel the tension in your lungs. And if you just relax, because of your natural recoil of the chest wall. Okay. Law of Laplace. This is again talking about the pressure and why we need surfactant. So pressure is inversely proportional to the radius of the alveolus. The bigger the alveolus, the lower the pressure. Air is not compressible. If you ever go scuba diving, you have those O2 tanks. They are compressed air. There's a ton of air in that tank. You can fit a lot of it because you can compress that stuff. You can't do that with liquid. Large radius, lower pressure. Small alveoli would be at greater risk of collapse without the surfactant there. So the surfactant keeps those little alveoli popped open, as well as that residual volume that you have always in your lungs and there. If you didn't have the surfactant, the pressure would be too great in those little alveoli and they would all collapse. So that's why surfactant is important. Okay, what's it made by? Type 2 alveolar cells, hydrophobic proteins, reduces surface tension between water molecules, prevents collapse. That's why it's so important with surfactant. Babies born without surfactant have that respiratory disease of the newborn. They can't breathe on their own because they don't have the surfactant. In babies, the lungs are the very, very, very last thing to be developed because you don't need them for 9 months. All the oxygen comes from your mother, so your lungs don't matter. That's why preemies have lung problems, because that's the last thing to be made. So usually if they're a preemie, we give them a shot of steroids, which kind of like helps the process along to mature the lungs faster. So that's why surfactant's important. And I just talked about that. Respiratory distress syndrome of the newborn. Okay. Regulation of breathing. How do we breathe and how do we regulate our breathing? Why does our breathing increase on its own without us thinking about it? And so forth. So there are two areas of the brain that deal with the motor neurons that control our breathing. The first one is our voluntary ones. So you can control your breathing. You guys do your physical exam. Okay, do a couple of big, deep breaths for me. You can physically control your breathing. Because it's voluntary, it's got to come from the cerebral cortex, because that's where all of our motor is, right? For all of our skeletal muscle, you want to breathe in and breathe out, you have to activate your primary motor cortex in the cerebral cortex. Involuntary breathing, so like when you're sleeping. Can you imagine if you had to think about breathing when you were sleeping? Everyone would be dead. So we don't have to think about it. They come from centers in the medulla oblongata and the pons. So we have peripheral chemoreceptors. We have central chemoreceptors. We'll talk about these in greater detail as we go through. We have receptors in the muscles and the joints. Why is that important to know? Fight or flight. What if you're running away from something? Your muscles are moving now, which then tells your medulla oblongata, your brainstem, hey, our muscles are starting to get fired now. They're moving faster. Maybe we need to breathe more to get more oxygen in there ready to go. So that's where that connection comes in. Stretch receptors in the lungs. If we're breathing heavier, our chest wall is expanding, more parts of our lungs are being ventilated. That will also cause a stimulatory response in our breathing if our lungs are being ventilated more. And the last one are these irritant receptors. Okay, coughing. Okay, if an irritant from the air gets into your lungs, you breathe it in, you start coughing. Or if you breathe or you drink fluid, you drink water, it goes down the wrong pipe, you start coughing like crazy. That's because you have irritant receptors that are there in case a foreign body comes into your lungs, you try and get it out by coughing. If you like hot foods, okay, if you ever have really, really hot stuff, you start hiccuping because you activated J receptors in your lungs from all the hot sauce, and it causes this type of reaction to happen with the breathing issues. So again, that's irritant receptors. Usually you breathe in that hot sauce, the fumes, it hits your lungs, starts causing an irritation to form. You start coughing, snot is going everywhere. Okay, mucus starts running like crazy to get all this stuff out. So brainstem respiratory centers, we have our motor neurons, makes sense. They all have to innervate the lungs, the diaphragm, to allow you to breathe better. Diaphragm is from the phrenic nerve, and that's from C3 to C5, phrenic nerve. And those that innervate the other breathing muscles arise from the thoracolumbar region of the spinal cord. Again, this is the voluntary way to breathe. So the pons influences medulla activity, has an apneustic center which promotes inspiration. So the apneustic center in the brainstem is going to promote inspiration, and we also need a way to slow it down. So we have a pneumotaxic center, which is going to inhibit your breathing, inhibits inspiration. So those are the two areas. Same thing we talk about with the nerves. We have stimulatory nerves and we have inhibitory ones. Same thing with our breathing. Brainstem respiratory centers control the breathing largely via the phrenic nerve. That's why I keep telling you, if someone has a massive stroke and they can't control the breathing, that means that this part of the brain has been affected. And for it to be that deep in the brainstem, it's a massive stroke that you had to have had to cause infarction in the brainstem. So as a prognosis for stroke patients, can they support their breathing and their heart rate? If not, it's a brainstem issue. So if you look here, here's the pneumotaxic area, and I'll put it in red. And we have our apneustic center, and I'll put it in green. That means go. Just like I said with the nerves, where the inhibition cells are matter. The direction of the impulse is going to go up. The negative inhibitory ones are right there at the end. They can cut off any stimulatory coming into the brain to increase your breathing. The pneumotaxic center can kick in and calm your breathing down. So the inhibition is the last one it's got to get through to allow for better control. The location of that pneumotaxic center is what makes it important. Okay, the rhythmicity center is just talking about, can you breathe regularly? Is it in? Is it out? Is it in? Is it out? It's a nice regular breathing. So that's where these respiratory centers play. Chemoreceptors. We need to know what's going on with the blood. Remember, we have a blood-brain barrier. So we have no way of knowing what's going on in the blood. So we have to have these chemoreceptors placed throughout the body that will sense the pH of the blood, the O2, the CO2, which will then go to the brain and tell you either to breathe more or breathe less, depending on what's happening with the O2 and the CO2 in the blood. This part is important. The carotid body is innervated by the glossopharyngeal nerve. So the carotids, when that's sensing the O2, the glossopharyngeal nerve is the one that does it. In the aortic body, it's the vagus nerve that does it. Okay, so those you got to know. which nerve innervates those chemoreceptors. This is just a way to put everything together. We have our spinal cord talking about our respiratory neurons. Our voluntary breathing obviously has to go to the cerebral cortex because that's where our motor system is. So for all the voluntary stuff, then it follows all that, the pons and all that stuff. Our automatic breathing bypasses the motor stuff because you don't need it. Just remember, breathing at rest is passive. With exercise, expiration is now active. Normally, it's all passive. So what effects do pH and CO2 levels have on ventilation? The main driving force for your respiration is not the lack of O2 in the blood, it's the CO2 concentration that drives your breathing. Yes, the O2, PaO2 is the main homeostatic variable, but to change your breathing, it's the CO2 that causes the most profound changes in your respiration. It's the buildup of CO2 in the body causes you to hyperventilate, to blow off that CO2. If you have too much CO2 or too little, you slow down your respiration so the CO2 can start building up again. So it's all about CO2 management. In hypoventilation, CO2 levels rise, called hypercapnia, and the pH levels fall. So in hyperventilation, you're breathing off all that CO2. Hypoventilation, you're not breathing enough. So you can't exhale the CO2, so it builds up in your blood. CO2 is acidic, carbon dioxide. That's why sodas, they're carbonated beverages. They are very acidic because of the carbon dioxide that's in it. When you get a lot of carbon dioxide in your blood, we attribute it to acidosis. So you guys start learning about acid-base. CO2 is an acid, and the base is the bicarb. Okay. In hyperventilation, now we're breathing way too much. We're blowing off all that excess CO2. The CO2 levels start to drop in our blood. We're reducing the acid, so the pH levels rise. We become more alkaline. When CO2 levels fall, it's called hypocapnia. Ventilation is controlled to maintain a constant level of CO2 in the blood, which will equate to a pH of 735 to 745. That is the normal pH of the blood, 735 to 745. And again, increased CO2 is the primary drive for breathing, which is why if you look at CPR these days, what don't you have to do really much anymore? Breathe the breaths anymore. You just compression. The compression is acting like an artificial heart to keep the blood moving. How much oxygen do we breathe in? What percent do we breathe in? 21%. If you measure the concentration of oxygen out in your expired breath, it's only about 19 to 20%. You only extract like 2% of the oxygen for your muscles. You still got 18 to 19% oxygen in your blood. You don't need to breathe in to get more oxygen. You need to get the pump working to pump that oxygen to the body where it needs it. That's where CPR comes into play. So by pushing the compressions, you're getting that heart pump to pump blood. The oxygenation is fine. It's going to be okay. So that's why I don't push the breathing anymore. Effects of PCO2 on ventilation. So you can see here with hypoventilation, arterial PCO2 numbers start to go up. In normal ventilation, we're there, and then hyperventilation, it drops all the way down. So start thinking how breathing alters your CO2 levels. If you hyperventilate, CO2 levels drop because you're blowing off all that CO2 by breathing fast. If you breathe really slow, you don't have time for all that diffusion to occur, so CO2 starts to build up in your bloodstream. So here's the chemoreceptor control of breathing. So if we have decreased ventilation, it's going to increase the arterial carbon dioxide levels. This is going to increase our plasma CO2 levels. In the brain, this excess CO2 drops the pH of your fluid. Okay? CO2 is acidic. We're getting a lot of CO2 now. Turns the blood a little bit acidic. It's going to drop it. We get those central chemoreceptors in the medulla oblongata that are going to sense CO2. And it says, hey, we're starting to get a little bit too much CO2 here, our acid is dropping, our pH is dropping, too much acidity. So it targets the respiratory center in that medulla oblongata, which is going to in turn stimulate spinal cord to increase ventilation. So we breathe, we pick up our breathing in hopes to lower the CO2. There's also a negative feedback. The opposite is true. If CO2 levels drop, we need to change our respirations accordingly as well. We also blood pH will drop. That is sensed by the peripheral chemoreceptors in the aortic and carotid bodies, which also are going to tell the respiratory centers, we have too much CO2, we need to increase our ventilation to get rid of this CO2. So that's how our chemoreceptors, the peripheral and the central ones, work together to alter your breathing depending on the CO2 concentration. Now we're talking about oxygen on ventilation. When does oxygen kick in? Okay, so what the oxygen does is it indirectly affects ventilation by affecting the chemoreceptor sensitivity to CO2. When O2 levels drop, it makes these chemoreceptors more sensitive to CO2. If your O2 levels drop, what do you think that means with your ventilation? Is your ventilation dropping or going too fast? Dropping as well. So if O2 levels drop, we're probably not breathing enough. And when they start to get low, it makes those chemoreceptors more sensitive to carbon dioxide. Like I said before, carbon dioxide is the main driving force for respiration. But O2 has an effect too, but all it does, it just makes those chemoreceptors more sensitive to carbon dioxide. So small changes in carbon dioxide will produce bigger results in the breathing. Okay, so low O2 makes those carotid bodies more sensitive to oxygen. So we have this thing called the hypoxic drive, where carotid bodies will respond directly to low oxygen dissolved in the plasma below 70. What is a normal oxygen in the blood? Like 98, 100, around there. Drop down to 70, hypoxic. That's going to kick in your drive to start breathing more by making the CO2 receptors more sensitive and picks up your breathing rate. So this is good to know, that like these first two columns. The stimulus is CO2. What monitors that? The aortic and the carotid bodies. What monitors pH changes? The aortic and the carotid bodies. But oxygen is only by the carotid body. The aortic body does not sense oxygen changes, just CO2 and the pH. Okay? So this is how our brain knows what's going on with our O2 and CO2 content. Let's take a break here, come back at 2:30. Okay, we'll get started. Try and get you out early again. So, these 4-hour blocks aren't so bad, are they? Go fast. So, they're what? Terrible? They're what? Terrible. Oh, I thought you were. Oh, okay. Okay. I know, it's fine. So, when we did cardio, I kept saying we're only worrying about the left ventricle, left ventricle, left ventricle. That's all we did. The right ventricle follows the same exact curves and plots and all that stuff. The difference is it's just on a lot smaller scale with regards to pressure. So the mean arterial pressure for the pulmonary system is only 10 millimeters of mercury. What is it on the systemic side? What's the minimum? Is 65. Normally it's a lot higher than that. But 85, 80 is a normal map for a healthy human. In the right side, map is only 10. The systolic pressure is 25 and the diastolic is 8. Very, very, very low pressure on the right side. But all the properties are the same. The filling, the diastole, the systole, all that stuff is the same order, everything's the same, just lower pressures. The left atrial pressure is about 5 millimeters of mercury. It's leaving at 25. So that 25 to 5 is the pressure gradient for the pulmonary system. So for pulmonary, left atrium or left ventricle, and where does it end up? Right atrium. Okay, so we talked about that. I'm sorry, this is the other way. Yeah, right ventricle to left atrium. So right ventricle is 25, atrium is 5. That is the difference to provide the flow through the pulmonary vasculature. On the systemic side, it's 120 to like 10. But on the pulmonary system, smaller, less resistance to flow, so it's easier to get through the pulmonary system, and we can survive on lower pressures. Having these lower blood pressures on the pulmonary system reduces the workload on the right ventricle, so it doesn't have to work that hard. And reduces excessive interstitial fluid formation. We don't want interstitial fluid formation. What is that going to do to our diffusion distance? Increases the diffusion distance. Therefore, your O2 diffusion is going to be altered by that as well. So we have this is just, again, reinforcing things. There's a series of lung problems which will actually exert a higher pressure on the right ventricle and cause the right ventricle to fail. So you get right-sided heart failure. So if you have right-sided heart failure, that means the right ventricle can't generate enough force to pump blood to the lungs. What's going to happen to your breathing? Your O2 sats. Not enough blood's getting to the lungs. Decrease. If the right ventricle can't pump the blood out, where's the blood going to get stuck and work backwards? Right ventricle to right atrium. Right atrium gets the blood from where? IVC. And if you work your way back, it goes all the way in your veins. Right-sided heart failure causes your legs to swell because the heart can't pump the blood out. Left ventricular failure, the left side of the heart can't pump the blood out, so work backwards. Blood's going to get congestive heart failure. But if the left ventricle can't pump the blood out, where is it going to get backed up? In the lungs. So left-sided heart failure has breathing problems, pulmonary edema, because that's where the blood gets stuck. So you'll see later on we get to different heart failures, why they have different ways. Pulmonary vascular resistance. What's the resistance in the pulmonary system? It's going to be different than it is on the systemic side. Because of the pulmonary, it's got to go to the lungs and back out. That's all it's got to do. The systemic side's got to go throughout the whole body in different systems. Okay, so pulmonary vascular resistance is low. And it allows blood to flow very easily throughout the system with low pressures. Resistance is shared between the arterioles, capillaries, and venules. So this gives rise to what's called alveolar and extra-alveolar vessels. We'll describe those in a second. The alveolar vessels are influenced by alveolar pressure and are compromised if alveolar pressure increases above vascular. So here's our alveolus, and the air is coming this way. And there is our capillary going right near it. When this alveoli gets enlarged and big, it exerts a pressure and can actually kink the vessel, kink it right there. And when that happens, the alveolar pressure is greater than the vascular pressure. What do you think happens to the vessel? Does blood get through that? Nope, blood doesn't get through. So you'll see how this comes into play later on. The extra-alveolar vessels are affected by lung volumes. Similar thing, alveolar gets big, those capillaries get stretched. So this is a graph looking at pulmonary vascular resistance on the Y and your arterial blood pressure on the x-axis. The recruitment and distension of pulmonary capillaries allows the pressure to drop over time. We recruit more capillaries. All these capillaries pop open. So what have I done now? I've increased what? All these capillaries are now wide open. They can take blood. We're going to reduce the pressure amongst all of it. We've increased the surface area, so therefore the pressure goes back down. We have a lot more vessels to accommodate all that blood, and the pressure goes down. So pulmonary vascular resistance goes down as you recruit and distend capillaries. When you start exercising, more parts of your lungs are going to open up, provide more blood flow to more parts of the lungs, reduces the resistance so blood can go easier through the lungs. Think about exercise. If the blood had to work harder to get through the lungs, you couldn't do exercise. You wouldn't have enough supply of oxygen to do anything. So having nice open vessels, lowering the resistance, allows flow to go much easier through the pulmonary system. Now, we're going to look at pulmonary vascular resistance as it relates to lung volumes. At low lung volumes, we get compression of those extra-alveolar vessels. When you compress the vessel, what's the radius doing? Decreasing. You decrease the radius, what happens to the pressure or resistance? Increases. Okay? So, low lung volumes, we get compression of these extra-alveolar vessels. We're compressing the vessels, resistance is going to go up. As we get to a more normal breathing, so our functional reserve capacity, we're going to operate at a lower end of this spectrum. Now, at high lung volumes, we also increase pulmonary vascular resistance because all the little pulmonary capillaries get stretched. If you stretch a capillary, a tube, what happens to the radius of that tube as you stretch it? It decreases. You decrease the radius of the capillary by stretching it. If anytime you decrease the radius, the resistance is going to go up. And that's why we have a high resistance at high lung volumes and at low lung volumes. Basically, the same thing is happening. Increased resistance in the alveolar capillaries increases the pulmonary vascular resistance. At optimal lung volumes, everything's okay. Remember, low volume, think restrictive diseases. High volumes, emphysema is where that comes in a problem. Capillaries are stretched, resulting in reduced capillary diameter, increases your pulmonary vascular resistance. Smoking destroys the alveolar membrane and corresponding capillaries. So by continuously smoking, you destroy your areas for gas exchange, less area for gas exchange. Therefore, breathing, you increase your breathing rate because your diffusion of oxygen went down. You have less surface area for diffusion, less ways to get oxygen in. We also have regional differences in our lungs. Right now, we are all upright. So according to gravity, where's the majority of your blood in your lungs going to be? At the base or the apices? The base. So at rest, we call them different zones. Certain ones are greater perfused than others. So if I talk about perfusion, what am I talking about? Blood. I'm talking about ventilation, breathing. Is there air in the alveoli or is there blood in the capillary to get exchange that can happen? So blood flow is greater at the base of the lung, at the apex, and we have these zones. So I'll describe it real fast here. Zone 1. Zone 1 is all the way down here at the bottom. So we're at the apices. Zone 1 is the apex. Zone 3 is the base. Zone 2 is just the middle zone. Nothing really there. Zone 1, this is at rest. Okay. Arterial and venous pressures are less than the alveolar pressure. Okay? Why is arterial and venous pressure low at the apices? There's no blood there. So there's no pressure. So they're low pressure in the apices because there's no blood there. So you get compression of these capillaries and no perfusion. So we don't have any perfusion of blood in the apices at rest. We call this alveolar dead space. They're ventilated, but they're not perfused. Okay, alveolar dead space. Air is in there, but because there's no blood in the capillaries nearby, gas exchange will never happen. Alveolar dead space. No O2 exchange, no CO2 exchange, there's no blood. You got to have both there. Zone 2. Now we're in the middle part of our lungs. Alveolar pressure is between arterial and venous pressure. So therefore, vessels are partially constricted and blood flow is limited. Zone 3 is the base. The arterial and venous pressures both exceed the alveolar pressure because there's blood there now. So the blood is popping up those capillaries, exerting a pressure in the arterial and venous system. It's greater than the alveolar pressure, so those capillaries stay wide open. And this has to do with the largest blood flow because we're at the base of an upright lung. So here's zone 3. Zone 3, arterial and venous pressure are both greater than the alveolar pressure, so the vessel stays open. You can see it right there. That vessel stays open. High hydrostatic pressure of the blood. Bless you. It's so high because it's the base of the lung, which has all the blood sitting in it from gravity. So more blood in the base exerts a greater hydrostatic pressure as well. Zone 2, arterial is greater than alveolar, but alveolar pressure is still greater than venous pressure in the pulmonary, and we get mild occlusion there, not much, but you get some occlusion of the vessels. Finally, zone 1, the alveolar pressure, because you're breathing, the alveolus are being opened because the air that you're breathing is greater than the artery and the venous pressure exerted because this is the apices. There's no perfusion right now. There's no hydrostatic pressure. Therefore, the alveolar pressure wins. You get that constriction right there, and you get no perfusion because of that. Okay? So those are the different zones of the lungs while you are upright. Do I have a picture? No. So if you lay down, head's up here, here's your chest, here's your lungs this way. If you lay down, zone 3 becomes this part. The blood is going to pool because of no gravity. So when you lay down, the anterior part of your chest becomes the no perfusion. The inferior portion, the superior or the inferior while you're laying down, gets all the blood just due to gravity. So when you're like that, when you're upright, all your lungs, the blood stays at the bottom. It's a bad drawing of the lungs, but you can get it. Took it away. Blood stays on the bottom. That's all. Gas exchange. How do we get rid of CO2 and how do we inhale O2? So we said before, 760 is a normal atmospheric pressure of all the things in the air. 760 at sea level. The higher you go, 20,000 feet in the air, you can see it goes all the way down to 340. These arterial pressure, the barometric pressures drop. What percent of the air is oxygen? 21. So if you did 21% of 750, you get 159. That's where that number comes in. This is still in the air, though. Okay? Now, look at the PO2 in the alveolus. It went down to 105. Why did it drop from 159 to 105 when it got into the alveolus? Humidity. We humidified the air. We added water vapor. It displaces some of that oxygen, so the oxygen levels drop. That's why the air O2 is not the same as the alveolar O2 because we humidified the air. We added some more stuff. 105 in the alveolus to 100 in the arterial blood. Which way are we favoring oxygen to move? Where is it higher? In the alveolus or the blood? Where's O2 higher? Alveolus. It's lower in the blood. Which way is O2 always going to want to go? Into the blood. That's where we want O2. We want oxygen in the blood, out of the air. If the if the gradients were opposite, it was 105 in the lungs, or in the blood, and 100 in the alveolus, which way would oxygen go? Into the lungs, which doesn't do us any good. So it's set up that way to provide the gradient so that oxygen will always go into the blood. So the significance of PO2 and PCO2 measurements, we only measure oxygen dissolved in the blood plasma. It will not measure oxygen bound to hemoglobin in the red blood cells. So what we're looking at is whatever oxygen is dissolved in the blood is what you're actually looking at with a pulse oximeter, not what that's bound to the red blood cells. When lungs are functioning properly, PO2 of systemic blood is only 5 less than PO2, and there's your 5. That's where that 5 comes in. So everything's working well, only 5 millimeter mercury difference between the outside and the blood, and that allows enough for gas exchange to occur. So this is one way of looking at it. So we have our capillaries, and we have the body cells. So this is the lungs up here. Here's your alveoli. And underneath it, we have it at the body cells. In the alveoli, coming back from the pulmonary arteries. This is all the blood that came from the system, right? All the deoxygenated blood that went to the whole body, dumped up all the oxygen to the working muscles and tissues, and got all that CO2 brought back in. When this blood returns back, the PO2 is only 40 and the PCO2 is 46. So you've extracted about 60 millimeters of mercury of O2 out of the blood into the system to provide energy for aerobic metabolism. In the alveoli, PO2 is 105, PCO2 is 40. Which way is oxygen going to go? Into the blood. We're at the lungs. We need O2 into the blood. Which way is CO2 going to go? It's 46 in the artery or the vein, pulmonary artery, and it's only 40 there. We're going to dump CO2 into the lungs so you can exhale it and blow it off. So the diffusion gradients have to be in that direction. Now we've gone through the lungs and we've dropped off all the CO2. We picked up all the oxygen. CO2 levels dropped to 40. O2 went all the way up to 100. Now we've saturated our blood. This same 140 goes through the whole body. And now we get to our cells. We're going to unload O2 into the cell, and we're going to pick up CO2 in the cell, from metabolism. And that's where these numbers come in. When you add up all the cell tissue that's going to dump all that stuff, by the end of it, right before it gets to the heart, these are where the numbers are. So just think, I'm at the lungs. I want to bring in O2, I want to dump off CO2. That's what the lungs do. If I'm at the tissues now, I want to dump off and unload oxygen to the tissue where they need it. And I'm going to take in the blood, all the CO2 and the waste product, so that the CO2 I can bring to the lungs and get rid of. Just always think about where you are. Am I at the tissue or am I at the lungs when you're studying this stuff? So how do we get transport of oxygen throughout our body? We have our hemoglobin molecule. So remember, the hemoglobin is like the crates. Each crate can carry 4 molecules of O2. So 4 jugs of milk or whatever. And you can load up hundreds and hundreds of crates into a truck. And that truck is the red blood cell. And all the little cartons, all the crates are the hemoglobins, and every milk jug is 1 unit of O2. So you can see how much a truck can hold of oxygen. Millions of hemoglobin per every red blood cell. Therefore, each red blood cell can carry over millions of O2 molecules. Your percent oxyhemoglobin saturation, which is what you do for a pulse oximeter, this is what's looking at percent oxyhemoglobin, that's total to hemoglobin. What hemoglobin is bound to oxygen and what's not. And we can see how well the lungs oxygenated the blood. Normal is 97%. You really never really had 100% O2 saturation. You're about 97%. That's what your normal is. So hemoglobin concentration. Anemia means you have less than normal hemoglobin. Polycythemia, higher amounts of hemoglobin because of extra red blood cells. Erythropoietin is the hormone made by the kidneys, which comes out when they sense low oxygen in the blood. The kidneys will kick out some erythropoietin, which will start making more and more red blood cells. So, loading and unloading of oxygen. So we load oxygen in the lungs, or it binds to hemoglobin. We unload it at the tissues. So we want to bind the hemoglobin in the lungs. We want to offload it in the tissues. If you can't do that, your tissues won't get oxygen. So we have to look at this oxygen hemoglobin dissociation curve. What percent on the Y is bound, and then looking at over your PO2 levels on the x-axis. So you get this nice little curve here. We unload at the arteries, and the veins have a PO2 of about 40. So 22% of our oxygen is unloaded in the tissues. You can see here is where we are PO2 with the systemic veins, and there we are with the arteries. So 100 to like, 70 something? That's kind of like what happens with the in the body. So this is the curve. We're going to talk about now how we shift this curve based off of different parameters. So pH on oxygen affinity. What is affinity? How tight you bind to something. So if something has very high affinity for something, they're going to bind very tight. If they have low affinity, they're going to let them go and release it. So the affinity for O2 decreases at lower pHs. So as your blood gets more acidic, the affinity for oxygen decreases. So we shift it to the right. The affinity for O2 increases at high pHs, so alkaline, and it's going to shift it to the left. And this is the Bohr effect, but you don't have to know what that is for the class, but if you've ever heard Bohr before, then this is what it's referring to. So that's pH. You can see here, just mathematically showing at a normal pH of 7.4, 5 units are unloaded to the tissues. When pH levels rise, become more alkaline, the affinity increases. So we increase the affinity. The hemoglobin is going to hold onto the oxygen. Extraction is only 3 because the hemoglobin had a high affinity and it held onto the oxygen molecules longer. 7.2 pH. Very acidic now. So acidosis decreases the affinity for oxygen, so it's going to unload oxygen easier at the tissues. And you can see that unloading goes up to 6.6. So again, just showing you, as you alter pH, what happens to the affinity for oxygen. Temperature. Temperature changes. How does that deal with oxygen? Hemoglobin affinity for O2 is decreased at increased temperatures. It's going to shift it to the right. If you're exercising, what happens to your body temperature? Increases. Is that going to help you exercise or hinder your exercise? Helps. Why does it help unloading of oxygen? As your temperature goes up, you get warmer, you decrease the affinity for hemoglobin and oxygen, so oxygen can get off easier to go into your tissues, so you can do whatever you got to do. Conversely, the colder you get, the higher the affinity. Okay, you've all heard stories, I'm sure, people that get stuck in a frozen lake, core temperature drops, bring them into the ER, you warm them up, and they come back to life. Because at freezing temperatures, the hemoglobin is going to bind to that oxygen and hold on to it for dear life. Your tissues will hold on to oxygen as well. So you can't declare someone dead until they're warm and dead. You have to revive them to normal temperature. If they're still dead, then they're still dead. Some of them wake up. If they do, that's great. But you can't declare someone dead if they're coming in, their body temperature is like 80. You got to get up to 98 before you can do that. So here, cold temperature, higher affinity for O2, it's going to hold on to it. Warm temperature gets rid of it, so you can exercise. And your O2 leaves easier the hemoglobin to get into your tissues to provide energy. This just summarizes what we talked about. So this one talks about how we figure out what our O2 delivery is and how does oxygen get around the system. So our blood oxygen content is O2 So the O2 is the amount of oxygen divided by the total volume of blood. That tells us what our O2 content is. Okay, our O2 is like whatever 50, our blood content is 5 liters, multiply it out, tells you what oxygen is. Of all the blood that has oxygen in it, 2% just stays dissolved in the blood. And that's what that hemoglobin, that pulse oximeter is looking at, what's dissolved oxygen in the blood. 98% of it is going to be bound to hemoglobin. So HbO2, they combine together, hemoglobin and oxygen together. So 98% of our oxygen is bound to hemoglobin, 2% is just dissolved in the plasma and floats around. And then this is just a summary of our hemoglobin dissociation curve. Know, you can fill in what is going to shift this to the right and what's going to shift it to the right, what's going to shift it to the left. So you guys can use this as a review to study later on the different ways we can bind to this. As a side note, carbon monoxide has a very, very high affinity for hemoglobin, more so than oxygen will. So if you get carbon monoxide poisoning, what it does is it bumps off all the oxygen off of the red blood cells so that carbon monoxide can join as well. If you don't have enough bound to the hemoglobin, your O2 levels drop, you get lightheaded and dizzy. A lot of these people who claim they find ghosts in their houses and everything, it's a lot of the times it's just a carbon monoxide leak in the house and it makes them loopy and they hear things. That's really all it is, just carbon monoxide poisoning. These are all old houses. They have carbon monoxide leaks and it makes them lightheaded and loopy. It's like if you go to an air bar and just get 100% O2 going in your nose, you get lightheaded after that. Same thing. So anyway, good review for all the different ways you can shift this curve to the left, pH, temperature, and then the likewise, other side. Carbon dioxide. How do we transport carbon dioxide? We talked about oxygen, carbon dioxide. 5% of carbon dioxide is dissolved in the plasma, whereas only 2% of oxygen is in the plasma. We also have carbaminohemoglobin, where it's going to attach to the hemoglobin molecule. 5% of CO2 will be bound to the hemoglobin, but the majority of it gets transported as bicarb. Okay, the CO2 gets mixed, turns into bicarb, and then later on we'll see how it shifts to go back to CO2. So we have something called the chloride shift. I want to draw this one out. We mentioned it a little bit the other day. We have CO2 plus water gives a reversible reaction to give you carbonic acid, H2CO3. This H2CO3 can also undergo a bidirectional change to make bicarb plus a hydrogen ion. What enzyme makes all this possible? We talked about it a little bit, but there's an enzyme that does all this for us. And this is carbonic anhydrase. Carbonic anhydrase. It provides the stimulus for that and for that. It does both. This is all one line. I just couldn't draw it on one line. But basically the CO2 to H2CO3 goes to the bicarb, and then this just connects to that. It's all one line going across. It can go in either direction. Okay? So we have tissue producing CO2. Through diffusion, it goes into the plasma. We know a small percent will remain there. Most of it goes into the red blood cells. Some of it will go as a carbaminohemoglobin, that's CO2HB. But the majority of it is going to follow this direction. Now, we've gone all the way down. We've produced a bicarb and a hydrogen ion. At the level of the tissues, we're at the tissue, we undergo what's called a chloride shift. So what happens is this reaction at the bottom happens. This is called the chloride shift. Chloride goes into the hemoglobin And the energy it takes to do that, it's going to spit out a bicarb called the chloride shift. This happens at the tissues. So that carbonic anhydrase turns that CO2 and water to a bicarb and a hydrogen ion. The chloride shift takes that bicarb out, dumps it into the plasma, and chloride goes into the cell. This is called the chloride shift. It happens at the tissues. This is how you turn bicarb, carbon dioxide, into bicarbonate that can now move throughout the system. So that's the chloride shift. The Bohr effect is here as well. Just think about it. If I'm at the tissues, I want to really, really load up O2, so a good affinity for O2, at the lungs. For CO2 at the lungs, I want low affinity. I want this stuff to bounce off so I can exhale it. So always think about, am I at the tissue or am I at the lungs? And once you know where you are in the body, then you know which way O2 should go and which way CO2 needs to go. And it all should make sense. We want to unload CO2 at the lungs. We want to load CO2 at the tissue. The opposite is true for oxygen. So here's the reverse chloride shift now. Now we're in the pulmonary capillaries, we're in the lungs. Now we have to reverse this. We want to turn that bicarb back into CO2 so that I can exhale all that. So we do a reverse chloride shift. We dump out the chloride that we absorbed, and bicarb comes back in. Do I have a picture? Yeah. So reverse chloride shift. Chloride comes back in, diffuses the bicarbonate ion into the red blood cell. The chloride left. At the tissues, it's the chloride shift. Chloride comes into the red blood cell, kicks out the bicarb. Now we're at the lungs. We have to turn that bicarb back into CO2 so we can exhale it. So always keep those things in mind. So at the lungs, it's the reverse chloride shift. Bicarb comes back into the red blood cell. The chloride ion leaves the red blood cell. That's the shift. Then that bicarb, through all this carbonic anhydrase, goes back to CO2 and water, and the CO2 you just exhale. And that's how you get rid of CO2. So understand the chloride shift and the reverse chloride shift, where they occur. And just think about it. It makes sense. At the tissues, we want one thing to happen. At the lungs, we want the opposite. Let me see how much more we have left. I don't want to get... Okay, we'll do a little bit of acid-base and then we'll call it. The acid-base stuff, we're going to start a little bit of it now. A lot of it's going to happen more when we get to the kidneys in the next unit, because the kidneys have a bigger role. The lungs have a small part. They both work together, but we'll start it now. So you have to remember what a normal pH is first of all. So 7.35 to 7.45 is a normal acid pH level in the blood. We have two different types of acids in the body. We have volatile and non-volatile acids. A volatile gas is regulated by breathing. We can convert it into other things and exhale it. They're considered a volatile gas. Non-volatile acids, lactic acid, fatty acids, ketones, are buffered by bicarbonate. So they're not regulated by breathing, they're regulated by the kidneys. So non-volatile acids are done by the kidneys, volatile acids are handled by the lungs. You can just breathe out that acid. Don't worry about that for now, we'll deal with it all when we get to the kidneys. So the first thing you gotta do is look at the pH. The pH is below 7.35, it's considered acidosis. That's the first part. Just figure out, is this acidosis or is this alkalosis? Don't worry about respiratory or metabolic yet. Just answer that first question. What's the pH? And am I acidotic or am I alkalotic? So we know we're below 735, so we know we are acidotic. Then all you do is you look at the bicarb and you look at the CO2. If the CO2 is greater than 40, we know we have a respiratory problem because CO2 is altered, which is a respiratory variable. If the bicarb is low, which means we're buffering a lot of acid, we're eating up a lot of our bicarb, there's not enough left, it's dropping because we're trying to neutralize all this acid, then we know it's a metabolic cause for that acidosis. So you have to know your normal values for bicarb and CO2s. Remember 40 and 24. Respiratory acidosis caused by hypoventilation, rise of CO2, increased CO2, pH decreases. These are all things causing acidosis due to respiratory. Metabolic acidosis, excess production of acids, or loss of bicarb, as in with diarrhea. Okay, people have profuse diarrhea for many days. Yes, they're going to be dehydrated, but you got to worry about metabolic acidosis as well, because in all the diarrhea, you're losing your bicarb there as well. So that's how you get the acidosis sign. If the CO2 is out of whack, how is it? Is it too high? That's acidosis. Is the bicarb low? Acidosis as well. Now we have the alkalosis side, the opposite side. And pretty much just the opposite is true. Look at the pH first. pH is greater than 7.45. We know we're in alkalotic blood. Then you look at CO2 and the bicarb again. If the bicarb is high, we have a lot of bicarb, makes us alkalotic. If our CO2 drops below 40, again, CO2 is the acid marker. When that drops, it means we're alkalotic. So you have to look at which variable is abnormal, match it to the pH, and you get your answer. Respiratory alkalosis, hyperventilation. When you hyperventilate, you're breathing a lot. You're blowing off a lot of CO2, which means your arterial CO2 is going to drop, right? Less than 40. You continue doing it, you can get a respiratory alkalosis. That's a respiratory cause of that problem. Metabolic alkalosis. Vomiting will cause metabolic alkalosis because you're losing a lot of bicarb and hydrogen ions in the vomit as well, your gastric acid juices. So all the hydrogens are leaving you alkalotic. So that's how you figure out alkalosis. Metabolic, it's a bicarb derangement. Respiratory is a CO2 derangement. This is just a review. Respiratory, metabolic acidosis. Don't worry about compensated yet. We're going to deal with that when it comes to the renal system and how we correct it. Here's the Henderson-Hasselbalch equation. You don't need to memorize it or use it. Just know that that's how we figure out the pH of the blood. And it's using bicarb and CO2 to do it. Makes sense because that's the two variables that we use to look at for metabolic or respiratory. Ventilation controls the respiratory component of acid base, so make sure you understand what happens if you hypoventilate versus what happens if you hyperventilate. What happens to CO2 with each? That'll tell you, are you going to be acidotic or alkalotic from there? And this whole thing puts the whole thing together. I just cut it in half and did each side separately if it was acidotic or alkalotic, but this is the whole picture put together. And here's some more things as far as what the lungs, how they're going to respond to the effects of these acid-base balance. Okay, it's 3:15, but I only have like 10 more slides. So I'm just going to finish out. On Thursday, it will just be open review. We'll do Kahoot. It's all so after today, this is all the material for the test next Monday. So Thursday will just be review. Okay, this will go fast. Effects of exercise and high altitude on respiratory function. So where are my exercise physiology people? Now no one wants to raise their hand anymore because they know I'll call them. Exercise, deeper, faster breathing to match oxygen utilization and CO2 production. The supply has to meet the demand. You have a demand for oxygen because you're exercising. The supply has to match it. You got to breathe more. You got to have a faster heart rate to deliver all those trucks faster to the body because the demand has gone up now. Okay, so hyperpnea or tachypnea is a fast breathing rate. So what happens during exercise? Ventilation goes up. Makes sense. You got to breathe more to get more oxygen available for diffusion. Blood gases, no real changes in blood gases with exercise. Nothing's going to change. O2 delivery to the muscles increased. O2 extraction by the muscles increased. Obviously, we need more oxygen in the tissues to provide energy for fight or flight, whatever you're running away from. Here's our blood gas measurements with regards to altitude. Okay, if you ever watch people who climb Everest, they gotta wear, a lot of them will have like O2 tanks and all that stuff because it's so high in the altitude that the O2 pressure is so low, you don't have enough to feed all your tissues. Some people do it without tanks. Some people obviously do. The people who live there, the Sherpas that bring all the equipment everywhere, they live in high altitude, they're used to it, their body has already adapted, and they're okay. So you'll see a lot of athletes. What they'll do is they'll sleep in like a hyperbaric chamber to simulate living in high altitude. So they sleep in those things, but when they go to work out, they work out at normal sea level so they can still do their activity. But when they sleep in high altitude. What's that going to do to your O2 tension? Decrease it, because you're in a hyperbaric chamber. So if O2 tension goes down, what organ senses that? The kidneys do. And what's the kidney going to release when it senses low O2 tension? Erythropoietin. What's erythropoietin going to do? Make more red blood cells, which allows you to do what? Carry more oxygen, which allows you to do what? Do more activity, because you now got more, bigger oxygen supply. That's where endurance training, they live high, train low, to promote more red blood cells. So you can see here at sea level, our arterial PO2 is like 90 to 85, 90 to 95. But if you look at 25,000 feet, you're down to 32 to 39 partial pressure of O2. So it drops a lot. So what does our body do to adjust to altitude? Okay, so the immediate response. You flew to Denver, you flew to Mexico City, you get off the plane. Immediately you're at a higher altitude. Immediately your body's breathing less oxygen because you're at altitude. What's your body going to do to adapt? The first thing that happens, decrease in PO2, makes sense. There's not a lot of oxygen in the air that we're even breathing. So our carotid bodies increase ventilation. The carotid bodies are going to sense the low O2 and kick in your breathing. So your ventilation goes up, so you're providing more oxygen, more air to the lungs to get all that going. We hyperventilate. Lowers the PCO2, causing a respiratory alkalosis to occur when you first land in a high altitude. Increased affinity of hemoglobin for oxygen. What is that going to do? Better loading of O2 in the lungs. So we increase the affinity for O2 by hemoglobin. So we're going to bind hemoglobin to O2 easier and faster. So this is a graphical way of doing it. Carotid bodies sense the O2, changes our breathing, so we hyperventilate. That will increase the proportion of fresh air to the alveoli, so we're getting more air coming into the alveoli for exchange. This PCO2 of the arterial blood is going to drop because we're hyperventilating. Causes a respiratory alkalosis to occur, which is going to increase the affinity for hemoglobin for oxygen. So we get better oxygen loading in the lungs is the first thing. So step one, the immediate response, we load oxygen better at the lungs. That's the first response. That's all that happens. Then, after a few days of being at high altitude, we increase our 2,3-DPG in our red blood cells. What that does, all you gotta know about that, it decreases the affinity of hemoglobin for oxygen. But what this does at the tissue level allows better unloading of the oxygen onto the tissues. So the immediate response, we load O2 better at the lungs. The intermediate or the middle response, we have better offloading of oxygen at the tissues, so your tissues get more oxygen easier after a few days of being in altitude. The last thing that happens after a few weeks, this is when we have the kidneys kick in with the erythropoietin. It takes a few weeks for this to occur. It doesn't happen immediately, but after days to weeks, kidney is going to sense the O2 drop. Increased erythropoietin goes to the bone marrow to start increasing your red blood cell count. And therefore, finally, you're able to increase the oxygen content of the blood. So this is how our body responds to altitude. First step, better loading of oxygen. Second step, better unloading of oxygen at the tissues. The third step, more red blood cells, more trucks, more oxygen delivering capacity in the blood. That's the final stage for altitude. And this picture puts it all together again, but make sure you understand immediate, intermediate, and what happens at the end. And we're done with pulmonary, so we got done early. So I'll see you guys on Thursday, just review, and we'll go from there.